Next will be the third lecture of the previous lecture series by Dr. Hiranthini De Silva, Mind Matters, addressing the anxiety and depression in primary care. Dr. Hiranthini De Silva is a specialist family physician and a senior lecturer affiliated to Department of Family Medicine, Faculty of Medical Sciences, University of Sri Jayawardenepura. From 2016 to 2018, Dr. Hiranthini was designated as the founder national chair of the Spice Route Movement Sri Lanka in World Organization of Family Doctors, which is well known as WONCA. She is a fellow of Royal Australian College of General Practitioners and currently serves as Honorary Secretary of Sri Lanka Association of Geriatric Medicine. Over to you, Hiranthini.
Thank you for your kind introduction. And I want to thank Madam President, Council and the Organizing Committee for giving me this opportunity to share some thoughts on this very important topic. So, mind matters. I'm sure we all have gone through at some point in time anxiety and sometimes even low mood, lack of energy, and I'm sure we have met so many patients as well. So, is it really a great problem? I think so, because several researches that have been done recently shows that with the COVID pandemic, that we have increased number of people presenting with mental health issues. And more recently, there was a study that's still not published, which was done in the state sector curative sector in the public sector, where there was a considerable number of patients presenting with depressive symptoms. So I hope that I will be able to cover some of these during this time. To start with, let's move on to a quiz. So you can scan the QR code and go through some of the questions that I will be covering during this lecture. So I'll just give you a couple of minutes. All right, so let's talk about this patient who's around 48 years, a businessman. So this patient has been seen by you for many years, and over time you have found some difficulties managing this patient. So there are patients who come and tell how important they are and how difficult for them to come for appointments. And so this patient is a businessman, and he talks about his successes, and also he's a workaholic, he has few friends and interests outside of work. Today he tells you that he needs something to help him to go to sleep. So then you go on a bit more and you find that this patient's mood is low, and that this has happened after he lost a large client 1 month ago, and that also he feels guilty that he fights a lot with his wife. So you further ask some other questions to find out what's going on, and you find that he has difficulty in concentrating. He no longer enjoys his usual activities that gives him some pleasure. He has difficulty in sleeping, and he also has loss of appetite. So on top of that, he finds that there are more issues coming up related to his client, and he uses alcohol to get to sleep, and he hasn't gone to work because he feels there is nothing that can be done, and he has thoughts of ending his life. You also find that there are no other issues related to his family. There's no family history or past medical history, so insignificant. So now when you encounter this patient, you have some questions coming to your mind. What am I dealing with? What are the differentials that I should consider? And am I dealing with a patient who is at risk of completing suicide? So what do we do now? So we have to find out, is it a mental health condition? So in this case, it's full-blown mental health issues are there. Still, we need to know, is it a mental health condition? So there are some tools that can assess us, can help us assist in diagnosing or giving us a clue to a diagnosis. So most of these are validated in Sri Lanka, except the last two. So we can use them in our setting. Of course, it will take some time. So in a busy OPD, we may not be able to. But in certain times, if we want to train other other healthcare professionals who are assisting us, we can include these assessment tools. So with our patient, you can see the patient had a low mood, patient had decreased interest, sleep change, he felt guilty, there was decreased energy, there was less concentration. So all the stuff that we, to diagnose a major depressive episode are here. And we can assess the tools to assess the severity. And so we have a diagnosis of major depressive disorder. So what are the other disorders that we need to consider? So of course, a bipolar disorder. Is this the first episode? So we need to see whether the patient has a history of manic, mixed affective or hypomanic episodes. We need to see, because this patient had an irritable mood, grandiosity, a sense of entitlement. So is this something new onset, or has it been long-standing and stable, which identifies with the person's personality? Is it an adjustment disorder with depressed mood? So again, there should be a very clear-cut identifiable stressor. What about personality issues? So narcissistic personality disorder. So where the patient has grandiosity, which this patient had, entitlement, and a need for admiration. So either this is narcissistic personality type, or what we call a hyperthymic temperament, where patients talk very energetically, very loud, and that is their temperament. So further assessment will be needed, maybe from the family members, and so on. So other thing is generalized anxiety disorder. So this can be confused because some of the symptoms overlap with depression. So you can see here in this table, there are symptoms that indicate primary depression, there are symptoms that indicate primary anxiety, and the symptoms that are shared between both conditions. So you can see here, if there is a variation in mood, and there is a distinct depressed quality to mood, negative cognition, suicidal thoughts, and decreased appetite or weight, more likely to be depression, whereas anxiety, people continuously worry, which is persistent, which is irrational, so that's anxiety. And of course, there are symptoms that are shared between both diagnoses as listed here. So what other diagnoses should we consider? Substance abuse. So this is again an issue that we need to consider. Is it alcohol abuse or withdrawal? What are the medical conditions that can cause similar symptoms? Again, I have listed some conditions here. So maybe medications like beta blockers, benzodiazepines, alcohol itself can cause these symptoms. So we need to exclude these in our history, examination, and maybe we need to do baseline investigations in the patients who are presenting to us with lack of energy or tiredness, depressed mood as well. Okay, so other than the diagnosis, what are the important considerations? Is my patient safe to be sent home with some antidepressants? Or do I need to admit this patient? Or do I need to do a further risk assessment? So there is this sad person's suicide risk assessment. So again, it's a tool. But what we need to know is, are these thoughts persistent or are they fleeting? So does the patient have a current plan? If it's a current plan, what are the methods that have been used? What about previous attempts? What was the method used? Is it lethal? Is there a family member who has committed suicide? And what are the protective factors? Some of the patients may have ideas, but they might not tell you unless you ask about it, because they might feel it's not suitable to tell. But some patients might tell you, but they might just say it's just fleeting. So some of younger patients might have these thoughts more than older patients in our setting, because they have lots of issues, especially with Sri Lanka going through a crisis situation. Sometimes they don't have any hope in their studies, financial issues. So younger patients will come and tell you about their low mood, and older patients may be suffering with chronic diseases, which we may be treating the physical problems, but are we addressing their mental health issues? So I have listed here possible indications for hospital admission. So other than what we talked about, we need to find about their social situation. So what are their supports? What are the issues they are having? Any relationship problems that they may be going through? So coming back to our patient, we find that the patient's mood, irritable mood and grandiosity is long-standing. Patient uses alcohol for sleep, and he feels that though he has some thoughts of suicide, but he has no intention of going through with it. So how do we manage this patient? So this is from Murtagh's edition 8, set a pace model of treatment. So what are we talking about? So as we said, we need to find out whether the patient is safe, and education. So a lot of our patients are embarrassed of such a diagnosis, so what do we tell them? A good therapeutic relationship is really important as we manage these patients, because they come back to you again and again, and if not, they will go from doctor to doctor asking for reassurance, but we need to have that relationship. So we talked about assessment. How do we assess? So characterizing, finding out the symptom profile, the severity, using the tools, and corroborating other history from maybe past history, maybe from their spouses or family. So there may be underlying issues that come up, and also considering the patient's coping style, social and financial status. So this is the set a pace model. Let's go to PACE. So in PACE, so we have psychological therapy, antidepressants, or combination of these, and ECT. So we need to offer psychological therapy for all patients. Now in Sri Lanka, we don't have this. So it might be that the GP has to provide some kind of psychotherapy. So patients don't have access to psychologists, and so some kind of mindfulness may have to be taught to our patients. So there are different types of psychotherapy. So one is interpersonal psychotherapy, which we deal with relationship, mindfulness-based, and CBT. So basic principle of CBT, so cognition may be beliefs, thoughts that the patient perceives, and we need to modify them and reinforce positive behavior while discouraging negative behavior. So I'm not talking about a psychologist's role, but few things that we can help our patients to rethink or have a realistic thinking and have some kind of adaptive responses. So it's a continuum. So you can see here cognitive behavior therapy, so where it's psychodynamic psychotherapy to behavior therapy. So why do we talk about psychotherapy? Because studies have found that with moderate depression, it has benefit equivalent to medication. And in severe depression, we go for medication first, but it helps to maintain remission in long time. So we can use this for so many mental health conditions. So mindfulness is one that can be used where it's based on meditation, where we focus on positive aspects of their lives and shut out distraction and negativity. So it's a useful way of helping patients to cope with stress. So coming to antidepressants, you all know the first line antidepressants, SSRIs, SNRIs are not available, and mirtazapine is available in Sri Lanka. So these are some of the side effects. So we can use these antidepressants to, depending on the patient profile. For example, some of these antidepressants like mirtazapine has a sedative effect, whereas it can be used to patients who have insomnia. So again, this is expensive drug, so we might have to go back to the SSRIs in our patients. But again, in the SSRIs, there are different adverse effect profiles. So we need to match our patient and the medication. So useful management guidelines would be mild depression, how we can use, and going on to severe depression. So when we talk about continuing treatment, so minimum of 12 months for an initial episode and 2 to 3 years in subsequent episodes. So we need to find out who are the patients who can relapse. Right, coming back to managing anxious patients. So these are the types of anxiety disorders that we manage. And so in DSM-5 criteria, OCD and PTSD are categorized separately, but they have a relationship to anxiety. So SSRIs are the mainstay when we take to medication. We need to choose it carefully, and we need about 6 weeks to 12 weeks for a response. So we need to start, because of the adverse effect profile, where patients can get anxious, we need to start at a lower dose than that of a depressed patient and titrate it gradually, because our patients sometimes react a lot for these medications, so we need to be sensitive and start at a lower dose. So cognitive behavior therapy is another way that we treat anxious patients. So we need to talk to these patients. So with generalized anxiety disorders, the main type of treatment would be cognitive behavior therapy. So let's look at few of them. So one is psychoeducation. So we need to talk about the type of anxious symptoms they are having. How dysfunctional are they? How is it affecting their activities? And the talking of the fight and flight response. I'm sure you have learned at medical school the flight and flight response. So this is what that's going through. So it's like the whole day they are waiting to flee away from something. So enlightening them will help them to understand, okay, what my symptoms are, and faulty thinking processes. So patient might, some common thinking errors would be like catastrophizing. Everything is going to be bad with me. Or even if there is positive outcome, they will always discount the positive but focus on the negative. They can also try to mind read people. Everyone thinks I am bad or I'm like this. So that's the thinking error. So this is why we need to know as family physicians what type of faulty thinking does the patient have. And then we move on to what we call cognitive reframing. So this is changing this faulty thinking. So this is about, I have given you an example of a patient who can think. For example, I designed a product that did not fully meet the job specification, and the customer is unhappy. So then what happens? So people in the management will find out. These are patients' faulty perceptions. Everyone will know that I made a mistake. This will damage my reputation. I am incompetent. So then the patient really thinks this is 80% of what they are thinking. And therefore they are distressed. 90% of the time they are worried. So now once you have identified this together with the patient, you find out, is there evidence to support these perceptions? Patient might say, yeah, the customer was unhappy. Next level is there any evidence that does not support this perception? So you go up with this. So, and then we help the patient to identify it, and then we help the patient to realistically think, is this perception correct or wrong? And finally, we reduce the patient's anxiety. So that is one way. Another way is behavioral experiment. So if I don't keep worrying about my children, something might happen. So the alternative perspective is, if I don't keep worrying about my children, it will make no difference to their well-being, but I will feel less anxious. So addressing these wrong beliefs will help us to finally get the patient to think correctly and stop worrying. So the last one would be facing fears. So patients might feel they are scared to go out, go to a supermarket. So we can use this graded exposure. So you can see here I have given an example going to the supermarket alone. So they have given over time, patient has increased their time spent in the supermarket, but reduced their time reduce the level of anxiety. So so in this time span, we talked about the differential diagnosis in depression and anxiety. What are the tools that we use to analyze the state and type of patients presenting with mental health issues, risk of patients, and the role of psychoeducation, therapies, and antidepressants, and the cognitive behavioral approach to manage these patients. Thank you.
Thank you, Dr. Hiranthini, for your attractive lecture. Now the time for questioning, as we told earlier. To start at my first question to Dr. Hiranthini, please come, the others also come to the stage. My first question, Dr. Hiranthini, in my practice, as you said that the depressed mood, right, it may be my fault that the depressed mood is very difficult to diagnose, right? But nowadays, a lot of beauty salons and beauty parlors, when patient comes, we can't very difficult to guess whether she is depressed or anxious, unless just talk one or two words with him. That's my experience.
True, that's why we need to proactively ask the patient, because we will, as family physicians, we will know what the patients are, unless it's a new patient, who are the patients. So patients do come and tell us what they are going through. They might not say they are depressed, but they might talk about other things. So then we need to, as you said,
yes,
rightly so, we need to detect that. Face will not tell us.